Hello, everybody. Welcome to the September edition of the Miller-Johnson Benefits Lunch Break webinar series. As you know, we host these webinars every month on the third Wednesday of the month at noon. We have 3 more webinars coming up yet this year. As you can see, here's the date: October 18, November 15, and December 20th. Topics are TBA. However, I believe that, like we have done in the past 2 years, our December webinar will be an opportunity for you guys to join and ask the benefits lawyer, and we will have pretty much every lawyer, if not all lawyers from our benefits group, on to answer questions. So you can ask health and welfare questions, executive compensation questions, retirement questions, Secure 2.0 Act questions. And we actually have one attorney that, if he can join, does a little bit of labor and employment, and maybe he'll address some employment questions, but you may be a little bit more limited on those. With that said, I believe we are going to continue these webinars, obviously, at least through the rest of the year, and we will be evaluating whether you all think they are worth continuing in the next year. And to that regard, we would ask, give us some upcoming topics if you'd like to hear about it. Again, they should be benefit focused, not employment focused. So we typically will address, new laws and new regulations, but sometimes we don't have those coming out, and would like to hear from you on what type of topics you'd like to see in these webinars. With that, let's get started. Today's topic are going to be the newly issued proposed regulations under the Mental Health Parity and Addiction Equity Act. Let's probably start out here with some background on the Mental Health Parity and Addiction Equity Act, MHPAEA, as I will refer to it. This is compliance with MHPAEA is becoming an increasing enforcement priority for the Departments of Labor, particularly the IRS and HHS. As you probably know, laws impacting benefit plans can often shift from administration to administration, but it seems that from going back to the Obama administration through the Trump administration and now with the Biden administration, the enforcement on compliance with mental health and substance use disorder benefits is one that has stuck around and only grown throughout time. So we haven't really seen that shift back and forth in MHPAEA regulation. So a little background: MHPAEA was passed in 2008. In 2013, we've got the initial final rule. And then, as we'll talk about later in this presentation, in July, we got a proposed rule making some significant changes, particularly with respect to non-quantitative treatment limitations. So what are the requirements under MHPAEA? So first of all, we have requirements on annual and lifetime limits. Now, let me say, I'll quickly address this just so you're aware, because they are still applicable. But from a practical perspective, because the ACA significantly limits the ability for non-grandfathered plans to impose lifetime and annual limits, we really don't see problems with these requirements. But under MHPAEA, if your plan imposes less an annual or lifetime limit on less than 1/3 of the medical surgical benefits, M/S stands for medical surgical, then it cannot impose annual and lifetime limits on mental health and substance use disorder benefits. Again, MH/SUD is mental health and substance use disorder benefits, and you'll see these acronyms used quite a bit through this presentation. If a plan imposes annual or lifetime limits on at least 2/3 of its medical surgical benefits, then it can impose an annual lifetime limit on mental health and substance use disorder benefits, with the caveat that those limits comply with the ACA. But it either has to be aggregated with the annual and lifetime limits on mental health substance use disorder benefits, either has to be aggregated with the limit on medical surgical benefits, or if you have a separate limit, it's got to be at least as great as the medical surgical benefits or higher. So for example, let's say I had $1 million annual limit on medical surgical benefits, and I wanted to have I could either say mental health substance use disorder benefits is also going to accumulate towards that $1 million limit. If I wanted to have a separate limit for mental health substance use disorder benefits, it would also have to be at least $1 million. It could actually be more than $1 million, couldn't be less. So what's interesting is mental health, MHPAEA actually requires parity in how a plan covers medical surgical benefits on one hand, mental health substance use disorder benefits on the other hand. But I guess the interesting part is you can actually discriminate in favor of mental health substance use disorder benefits, so you can cover them more generously than you can medical surgical benefits, but the opposite is not true. So financial requirements and quantitative treatment limitations. Under MHPAEA, a plan cannot apply a financial requirement or a quantitative treatment limitation on mental health and substance use disorder benefits that is more restrictive than the predominant level. I want you to remember that term, predominant level of the financial or quantitative treatment limitation that applies to substantially all, remember substantially all, of the medical surgical benefits in the same classification. And we'll get to these classifications in a minute. So what are financial requirements and quantitative treatment limitations? Well, it's pretty straightforward. Financial requirements, include anything that's a requirement related to money, right? So deductibles, co-payments, which are generally set dollar amounts, co-insurance, which are generally percentage of cost sharing, out-of-pocket maximums. And similarly, quantitative treatment limitations are any type of limitations that can generally be expressed quantitatively or numerically. So annual, episode, day, or visit limits are quantitative. And so what does this substantially all and predominant level mean? So first of all, when you're determining whether your financial requirements and quantitative treatment limitations comply with MHPAEA, you have to look within each classification, and again, we'll address those in a minute, and look at, hey, does that financial requirement first apply to substantially all of the medical surgical benefits, which means at least 2/3 of the medical surgical benefits. And when you're determining whether it applies to 2/3, you're actually looking at the plan's expected payments of medical surgical benefits within that classification. If an actuary determines that plan level claims data is not going to be creditable to make this determination, it is permissible for an actuary to use claims data from other similar products. So if you're self-funded, maybe other self-funded plans. If you're fully insured in the large group market, maybe other fully insured groups in the large group market. Or if you're self-funded or fully insured in the small group market, other fully insured in the small group market. So what's interesting about the substantially all requirement is you have to hit the 2/3 threshold. So let's say you have, in a particular classification, you have a co-payment and a co-insurance requirement. And when you do the math, it turns out amazingly that co-insurance applies to 50% of the medical surgical benefits in that classification, and co-payments applies to the other 50% of the medical surgical benefits in that classification. Well, neither co-insurance nor co-payments meet that 2/3 threshold. So what does that mean? It means you can't apply co-insurance or co-payments to any mental health or substance use disorder benefits in that classification at all. You can't do it because you haven't hit that 2/3. So you may have to think about a plan redesign. Now, if you do hit that substantially all requirement, the next is potentially a predominant level analysis, which means when you look at what the financial requirement and quantitative treatment limitation is, if it has different levels, what level can you impose on the medical surgical benefits? So if there's a single level that applies to more than 50%, you can use that. But let's say you have, for example, multiple co-payments. You have, $50 for certain $50 co-payment for certain specialists, 30 for other specialists, and 10 for just generic providers. And none of these limits actually apply to more than 50%. Well, then you have to start aggregating. You look at 50 and 30. Does that apply to 50%? If so, then you can apply the copayment at the 30%, the lower level, to the mental health surgical benefits. If you still can't get to 50%, then you got to look at 50, 30, and 10 aggregating them together. If that gets you over 50%, which it arguably should, then you can impose the 10% copayment, which again is the minimum of that aggregate amount. Non-quantitative treatment limits. This is a term that maybe all of you were not familiar with until recently. This has really become a major issue with respect to DOL enforcement. Under the old rule that was issued back in 2013, you'll see that under the terms of the plan as written and operated, any processes, strategies, evidentiary standards, or other factors used to apply non-quantitative treatment limitations to mental health and substance use disorder benefits in a classification must be comparable to and applied no more stringently than the processes, strategies, evidentiary standards, or other factors used in applying that NQTL or non-quantitative treatment limitation to medical surgical benefits in the same classification. So when we looked at quantitative treatment limitations and financial requirements, it was a mathematical test. It may not have been easy to do, and we would have needed our TPA or insurer to help us because we'd have to look at claims level data. You can see that this test is much more subjective. So you could arguably under this test, and in fact, the final rule issued in 2013 had an example of this of an NQTL, which we'll talk about, give you some examples like prior authorization, which applied to some medical surgical benefits in a classification, and some medical, but not all, and some mental health substance use disorder benefits in the same classification, and may have applied to actually more mental health substance use disorder benefits in that classification. That was arguably permissible as long as it was subjectively comparable to. So there was flexibility there, which we'll see we're going to lose some of that flexibility, but it also left what's comparable to. As you know, reasonable minds can disagree. So here are, I won't read through all of these, the NQTL examples. This is a non-exhaustive list, so keep that in mind. And the new regulations, which we will talk about later on in this presentation, did modify this list slightly. Again, these are examples. They are not an exhaustive list. So we could have both under the examples provided in the old regs and the examples provided under the new proposed regs, we could have limitations that are NQTLs that are not specifically listed. So what are the classifications when we do our testing? We have 6 primary classifications. That's inpatient in-network is one, second, inpatient out of network, third, outpatient in network, fourth, outpatient out of network. Those can be kind of a tongue twister. 5, emergency care, and 6, prescription drugs. And then potentially, if we need to, so if we have some testing problems, we can subdivide a few of these primary classifications. So the net inpatient and outpatient in network classifications can be further divided by network tier, and then outpatient benefits can be subclassified into outpatient benefits can be further classified into office visits and basically all other outpatient items or services. So again, in further subdivisions, and there is actually a prescription drug subclassification tier for formularies that have various tiers. I apologize, that's not listed here, but what's important is we can't divide things into smaller buckets than what we have here. This is the smallest that we can do. Last February, we did, or maybe it was February of 2021. I apologize. I did a webinar as part of this series, so it is on our firm's YouTube page on changes made to the Mental Health Parity Act by the Consolidated Appropriations Act of 2021. And namely, the big change under this act is that plans that were subject to MHPAEA had to perform an analysis and document whether the NQTLs imposed under the plan complied with MHPAEA. And this caused and we'll kind of talk about what's required on that, that comparative analysis, but this caused a lot of consternation amongst plan sponsors. Because as you can imagine, and as you'll see, we don't have the data to do this, or necessarily the expertise to do these comparative analysis. So plan sponsors would go out to their TPAs if they were self-funded, or their insurers if they were fully insured, and say, can you do this for us? And what they'd find is they'd often get, no, we can't, or we don't have it. Now, it seems that those answers are changing, but at that point, it was like, well, what do we do? Do we not do it? Do we just cross our fingers that nobody's ever going to ask for it? There were other third parties that were willing to do these for you, but it came with quite a price tag. Anecdotally, I heard some providers were charging upwards of $50,000 to perform one of these analyses. Now, I do know that some providers have started to prepare them and provide them. Some have said, hey, we've got them. We're not willing to give them to you because they think a lot of the information in there is proprietary. But if you contacted by the Department of Labor, IRS, give us a call and we'll provide it. And we'll talk about that here in a little bit, because what we found, or what the Department of Labor has found, is that these comparative analyses are far from what they consider sufficient, at least the ones that have initially been prepared and provided. So for plans that provide mental health and substance use disorder benefits impose NQTLs, the insurer plan must perform and document this comparative analysis on the design and application of NQTLs. That's kind of the basic requirement. The comparative analysis, again, must demonstrate this subjective standard that you're basically not, you're imposing NQTLs on mental health and substance use disorder benefits in a way that's comparable to medical surgical benefits. And again, that's really a gray area. Reasonable minds can disagree. It's very subjective. Here's the scary part. It's beginning February 10, 2021, which was just a mere 45 days after the Consolidated Appropriations Act was passed. The CAA said that, hey, plan sponsors, upon request from the federal government, you have to disclose your comparative analysis along with these other elements, specific plan or coverage terms regarding NQTLs, an description of all the mental health substance use benefits which the NQTL applies, the factors used to determine those NQTLs, these evidentiary standards, and specific findings or conclusion that you reach that basically these NQTLs comply with MHPAEA. And you had a relatively short time frame to turn these over. Generally, it was only 10 days. Now, I understand that the federal government at its initial request were flexible in extending these timeframes, but they have indicated in the proposed regulations that, hey, plans have had, over 2 years now that they've known that they've had to have these, so we're going to tighten up. So you're going to have to provide one with generally within 10 days without extenuating circumstances. And then if the federal government makes an initial determination of non-compliance, you're going to have a limited time to reply or to fix that, generally 45 days. Now, that 45-day period, if you're working, you're working with the departments, they're more likely to extend that time period. But if you are not able to work with it, they will issue a final determination of non-compliance. And really, what does that mean? That means that, unfortunately, within 7 days, actually, this slide is a little bit accurate. It says the DOL, IRS, or HHS will notify all participants in the plan that it doesn't comply with MHPAEA. You actually have to notify your plan participants that the plan doesn't comply with MHPAEA. And the new regs give some guidance on what those notifications. And there has been 3 plans that the Department of Labor and 2 that HHS have found and issued final determinations of noncompliance, and they have had to send all of their plan participants with a notice that basically says, our plan doesn't comply with MHPAEA. And if you're familiar with retirement plan investment fee and record-keeping fee litigation, it's only a matter of time before the plaintiff's bar gets a hold of this concept and start seeing these notifications. And I think that class action lawsuits for MHPAEA violations are something that are certainly coming down the pike. Additionally, and this is again how the plaintiffs bar may be able to find these violations, Congress has to file an annual report to Congress and identify the plans that didn't comply. So, in fact, in the most recent report to Congress in 2013, the DOL identified 3 specific plans: plan name, plan identification number, plan number, or I'm sorry, EIN of plan sponsor, plan identification number, and why the plan didn't comply. So they're going to pick that up. I'm going to pause here for just a second. We got a question. It says, so the penalties are potential litigation and not fines from the DOL, IRS, and HHS. Certainly the penalties are potential litigation, but the Department of Labor, IRS, and HHS also have the ability to impose penalties. So the IRS, for example, the requirements that you comply with basically all ERISA, including the Mental Health Parity and Addiction Equity Act, is a requirement under IRS or Internal Revenue Code Section 490 ADHD. And each time when a plan does not comply with those requirements, you are potentially subject to a $100 per day per affected participant excise tax. So, for example, if your plan doesn't comply with MHPAEA, that arguably affects every participant in the plan. If you've got 100 participants, that's $365,000 a year in penalties. 100 participants times $100 times 365 days in the year. DOL can also impose civil monetary penalties. There's not a set amount. They have a lot more flexibility in doing those. The good news is at least where the departments appear with their enforcement litigation right now is not necessarily to impose fines, but to help with compliance. I should also mention that in some of the instances, the departments have their enforcement mechanism has been said, hey, that NQTL didn't comply with MHPAEA. You have to remove it, and you have to reprocess claims and approve claims. And therefore, while it's not a penalty, your plan may end up having to pay claims that were previously denied. And I should point out, if I didn't say this, feel free to use the question and answer function on here to ask questions. I will try to address those as those come in to the extent that we have time. All right, moving on to the proposed regulations. The new proposed regulations were issued July 25, 2023. They were almost 400 pages in length, so it certainly was quite a bit to digest. Not to mention, they were issued in conjunction with a technical release, which we'll mention here in a few minutes, an enforcement fact sheet about the department's past enforcement activities, the 2023 report to Congress, and a MHPAEA guidance compendium. And what that guidance compendium is just links to other private and public resources that plans can use to help ensure that their plans comply with MHPAEA. We are really only going to focus, due to time constraints, only going to focus on the proposed regulations. And I think it would just be hard to keep people's attention for very long if we addressed all these. But the technical release and these other materials may be the subject for future webinars. So if finalized, these proposed regulations are scheduled to take effect for plan years beginning on or after January 1, 2025. But of course, that could be delayed because before they take effect, you have until October 2nd of this year, or interested parties do, to submit comments on the proposed regulations. The departments will review those comments and issue final regulations. And so if those aren't issued significantly before January 1, 2025, which I doubt will happen, that delay date may be pushed back further. Keep in mind, though, these regulations generally contain a lot of helpful tips about the way the DOL is currently interpreting MHPAEA compliance and therefore enforcing it. So again, one of the penalties, which we won't necessarily talk about in this webinar in detail, but that I mentioned, is you may have to remove your non-qualified treatment limitation and reprocess claims. The department has already forced plans to do that in current enforcement actions. The proposed regulations generally impact NQTLs. So we talked about quantitative treatment limitations and financial requirements. those are largely unchanged. The requirements for those are largely unchanged from the 2013 rule. So quickly, what are the new requirements for NQTLs? So the NQTL that applies to mental health substance use disorder benefits can be no more restrictive than the predominant NQTL that applies to substantially all medical surgical benefits in the same classification. So for those of you that were paying attention, this sounds very much like the current requirement that applies to QTLs, or quantitative treatment limitations, and financial requirements. And it is with slight variation. So this test certainly removes some of the subjectivity of the test that previously applied under the 2013 rule to NQTLs. Again, and we'll talk about this in more detail later, so I'll get into that, but the calculations are, like I said, are similar to QTLs. Processes, strategies, evidentiary standards, or other factors used in designing and applying an NQTL to mental health substance use disorder benefits must be comparable to and applied no more stringently than those used in designing and applying the NQTL to medical surgical benefits. And in here in parentheses, I have what these requirements are combined. So we have the no more restrictive requirement. This is the design and application requirement. This is also should look familiar because this is very, very similar to the old rule. But as you'll see, we added in the requirement not only in the application of the NQTL, but designing the NQTL, which of course, when we talk about designing, that has to be a component of your comparative analysis. Finally, this is kind of the big one here, is plans must collect data such as claims denials for NQTLs that are applied to mental health surgical benefits and compare that to how it's applied to medical surgical benefits. So in the past, where MHPAEA required basically the process to be in parity between mental health and substance use disorder benefits, not necessarily the outcome, this data evaluation says, hey, we're concerned about the outcome as well. And in fact, the Department of Labor in audits is requesting claims information to do these analyses already. So when you're doing this evaluation, if you identify a material difference with respect to this data, that's a strong indicator of non-compliance with MHPAEA and requires additional action. And we'll talk about what that means. Now, with respect to network compensation, a material difference is not an indicator of non-compliance. It is a MHPAEA violation. And again, we'll drill into this here in a few minutes. So the no more restrictive requirement. Again, the NQTL that applies to the mental health substance use disorder benefits can be no more restrictive than the prominent NQTL that applies to substantially all. So again, substantially all, just like the QTL test, is 2/3. And again, it's based on expected plan payments within the classification. Now, if an actuary determines that claims level data for the plan is not credible, it can use other similarly situated product claims data to make this analysis. The predominant, though, is a slight variation. Remember, in the QTL, it was greater than 50%. Here, it's the most common or frequent valuation of the NQTL. And I have an example to go through. But the proposed regulations, address or acknowledge the fact that NQTLs may not fit in this predominant substantially all analysis as easy as QTLs, and so they've asked for comments on this. So we'll see if we get a more definitive definition of prominent in the final rules. And if you fail these tests, but you've applied these NQTLs due to independent professional, medical, or clinical standards, or standards to detect fraud, waste, or abuse, then there's no compliance violation, but that is going to be interpreted very, very tightly. The regulations even point out that this is not meant to be any type of loophole. And if that agencies start issuing additional standards to allow plans to evade compliance with MHPAEA, additional guidance may come out to limit that ability. So here's a no more restrictive example pulled right from the regulations. A plan requires prior authorization from the plan's utilization reviewer that a treatment is medically necessary for all inpatient in-network medical surgical benefits and for all inpatient in-network mental health substance use disorder benefits. I'll pause right here. So the first requirement is, remember, we had to hit that substantially all threshold, which is the 2/3 level. Here, we don't even really need to look at claims data since it applies to all medical surgical benefits in this classification, in the inpatient in-network classification. We've easily made that, we've without a doubt satisfied that substantially all threshold. Moving on, while inpatient in-network benefits for medical surgical conditions are approved for periods of 1, 3, and 7 days, after which a treatment plan must be submitted by the patient's attending provider and approved by the plan, the approvals for 7 days for medical surgical benefits are most common. That means that the predominant level out of 1, 3, or 7 days of a prior authorization is 7 days. And so if the most common prior authorization for mental health substance use disorder benefits has to also be at least 7 days. The example in their regulations actually go on to say, in this example, the most common approval for mental health substance use disorder benefits was only 1 day, and therefore we have a MHPAEA violation unless the plan can show that the NQTL was the basis of independent clinical data or, to prevent fraud, waste, or abuse, which again is going to be interpreted very narrowly. Second requirement is design and application requirement. So again, the processes, strategies, evidentiary standards, or other factors used in both designing and applying an NQTL to mental health and substance use disorder benefits must be comparable to and applied no more stringently than those used in designing and applying to NQTLs to medical surgical benefits. So again, this is similar to the previous requirement applicable to NQTLs, but it added this new design in addition to the application. Furthermore, we're not going to address these here, but it provided new proposed definitions for evidentiary standards, factors, strategies, and processes. So this should help, even though this is still a very subjective test, these definitions will help plans and their TPAs or insurers perform this subjective test. What is clear is you can't use factors for evidentiary standards if the information or evidence or standards discriminate against mental health substance use disorder benefits. And again, there are exceptions if a factor is otherwise discriminatory, but it was independent professional or based on independent professional or clinical standards are determined to be not discriminatory, and standards related to fraud, waste, and abuse are determined not to be discriminatory. So while these aren't exceptions, it's just a statement that these types of factors are going to be determined not discriminatory, again, interpreted very tightly. Information is considered discriminatory if it's biased or not objective in a manner that results in a less favorable treatment to mental health substance use disorder benefits. Still looking for guidance on this. I hope that we get that. The one example that the regs give, or the preamble the regs give, is say we're relying on historical plan data at a point when MHPAEA didn't apply. That we couldn't rely because that is going to be discriminatory. Finally, the data evaluation requirement. The data application requirement, so there's kind of a twofold test here. So we have the data evaluation requirement for any NQTL that's not based on network compensation, and then we have the data evaluation that for NQTLs that are based on network compensation, which is the makeup of the plan's network with respect to who's included from a medical surgical provider to a mental health substance use disorder provider. So non-network compensation NQTLs, the proposed rules leave open the possibility to address additional data elements that need to be evaluated, but specifically mention at this point the number and percentage of relevant claims denials and any other relevant data to the NQTL or required by state law or private accreditation standards. Again, I'm hoping for some more clarity on this, either through sub-regulatory guidance or in the final rules. And that after you do this evaluation, if the data reveals a material difference in access to mental health substance use disorder benefits, that's a strong indicator of a MHPAEA violation. And therefore, it doesn't necessarily mean you have a MHPAEA violation. It's a strong indicator, and you have to take reasonable action. Reasonable action are taken based on the facts and circumstances. So maybe we have to modify the NQTL. Maybe there's a justifiable reason that the NQTL appears to be more discriminatory or limit access to mental health substance use disorder benefits. Regardless of what it is, we have to take that reasonable action, and that action has to be documented in the plan's NQTL comparative analysis. So again, that's another element of that NQTL comparative analysis. We have four set data elements for when we're looking at NQTLs that apply, that are based on network compensation. The first is out-of-network utilization. We need to compare the percentage of covered versus submitted out-of-network claims for both mental health and substance use disorder benefits compared to medical surgical benefits. Percentage of in-network providers actively submitting claims. We have to collect data to evaluate the percentage of in-network providers who submitted no in-network claims and percentage of in-network providers who submitted claims for fewer than 5 unique participants. And the idea here is the departments are looking for ghost networks, a network that includes providers that say, hey, yeah, we'll join your network, but we really don't have any intention to providing any services for one reason or the other. This is actually kind of an issue that's coming up under the No Surprises Act too, that providers think that plans, TPAs, insurers are using ghost providers that are never going to provide the services to lower the QPA amount, but that's a whole discussion for a different day. Time and distance standards for participants to obtain mental health benefits. So must include percentage of participants who can access within a specified time and distance by county type, at least one in-network mental health substance use provider and one medical surgical provider. For those of you that are familiar with Medicare Advantage plans are currently subject to those requirements. We expect them, in fact, regulations even say we're going to use the same county type, so whether that be urban, suburban, rural. So I expect I expect this requirement to apply to be very similar to what currently applies to Medicare Advantage plans. Finally, the fourth data element that must be tested is reimbursement rates of in-network medical surgical providers compared to medical surgical providers. So again, are we reimbursing, is our plan reimbursing mental health substance use disorder providers significantly or materially lower than what we're reimbursing medical surgical providers? The one difference, as we indicated earlier, if you find a material difference there, it's going to indicate a MHPAEA violation. However, even if we have a MHPAEA violation, the departments may not take enforcement action if the plan can demonstrate that the violation is due to a shortage of mental health substance use disorder providers in the geographic area. That's not the plan's fault. The plan is taking actions to resolve this disparity and that they're otherwise compliant with all other aspects of MHPAEA. The technical release, which was released in conjunction, with these proposed regulations, includes a number of requests for additional data elements or other data elements related to network compensation that should be collected and evaluated. And also, because this is so important, proposes a potential safe harbor that if data comes back and meets some type of uniform standard metric, then at least until the first period of time, the plan will be deemed under the safe harbor as complying with the network compensation requirement. Finally, the proposed regs, and this I think is going to be interesting to a lot of folks out here because I get a lot of questions about whether plans have had to cover ABA therapy for autism spectrum disorder diagnoses. And I would have said that has changed over time. In 2013, I advised a lot of clients that, hey, if you want to cover this, you can, but if you do, you probably don't want to put any limitations on it. You want to cover it just like any other benefits, but maybe the safer road is just to exclude it all. It appears that exclusions of ABA therapy are considered to be a MHPAEA violation. So the minimum benefit requirement under the old rule said, hey, if you have our plan that provides mental health substance use disorder benefits in one classification, you have to provide mental health substance use disorder benefits in all 6 classifications. Now, that was just a requirement. You just have to provide mental health substance use disorder benefits in all 6 classifications. So plans may have been able to escape this by providing very minimal mental health substance use disorder benefits in certain classifications. So for example, they provide prescription drugs. That's a classification that a drug that's related to mental health or substance use disorder. Well, then they have to provide, mental health substance use disorder benefits in the outpatient out-of-network classification, and maybe they just did very meaningful services were available there. New rule says now you have to provide meaningful benefits in all classifications. So the proposed regs give two examples, and the first one I think is going to be interesting. A plan covers treatment for autism spectrum disorder and covers outpatient out-of-network developmental evaluations for ASD, but excludes all other benefits for outpatient treatment for ASD, including ABA, when provided on an out-network basis. The plan generally covers the full range of outpatient treatments and treatment settings for medical conditions and surgical procedures when provided on an out-network basis. In this exam, the plan violates the meaningful benefit requirement because the plan only covers one type of ASD, which is developmental evaluations, and the outpatient out-of-network classification excludes all other benefits. So if you have a plan that provides robust coverage of services, even on an out-of-network basis for outpatient services, and the plan covers mental health substance use disorder benefits, then you're probably going to have to cover that, mental health substance use disorder benefits in the outpatient out-of-network. So, I've seen a lot of plans that have adopted the providing ABA therapy, but it's limited to in-network. This meaningful benefit requirement may mean that we need to cover this on an out-of-network basis as well. The second example relates to eating disorders. So a plan generally covers diagnosis and treatment for eating disorders, but specifically excludes coverage for nutrition counseling to treat eating disorders, including in the outpatient in-network classification. Nutrition counseling is one of the primary treatments for eating disorders. The plan generally provides benefits for primary treatments for medical surgical conditions in the outpatient in-network classification. Again, this plan violates the meaningful benefit requirement because the exclusion of coverage for nutritional counseling for eating disorders results in the plan failing to provide meaningful benefits in that same classification. So again, these are two examples, and I expect the final regulations to dive into this more, but this is kind of, the regulations focus on particularly these three new requirements for NQTLs, but kind of slide this one in the back door. So more to come on that. At this point, I don't see any open questions, but feel free to, I'll stick around here for a few more minutes to address any questions that come in. Again, the regulations also addressed content requirements for NQTL comparative analysis. We've got enforcement actions addressed in the report to Congress. Those will likely all be subject of future webinars, but I wanted to focus this one on particularly the three new requirements that are proposed to apply to NQTLs and this meaningful benefit requirement. With that, I'll give a few more minutes for questions. Feel free to type it in. So I see a few more questions. So looking at network compensation or composition, only claims data, not who is in the network. No, they will, in looking at network compensation, they will look, can I access an in-network mental health substance use disorder provider on the same basis as I can a medical surgical provider. So we're looking at four data elements, at least in the proposed regs, which I'll go back to cover, not just claims. So we have out-of-network utilization. So this is claims, percentage of covered and submitted out-of-network claims, and then actively submitted claims. But then we have time and distance standards. So how long does it take me and how far does I have to drive to get a mental health access to a mental health provider? They're also looking at reimbursement rates. So while there is a claims element, it's not just claims. It's not just claims data that they're looking for in doing the network compensation analysis. So what do you suggest a self-funded do to comply? We do not have the resources to do this ourselves. Yes, this is kind of, you're between a rock and a hard place. I think you should continue to keep on your TPAs to see if they will provide this for you. Interestingly enough, the regulations have said that this this comparative analysis is one of the documents that plans are considered to be operated by. So under ERISA, you need to, upon participant request, you need to provide this comparative analysis within 30 days, or potentially face a penalty of $110 per day to the extent that it's not your responsibility for failure to provide the document. So one maybe out of the box or kind of aggressive way to do this is, if you're in charge of the plan at the employer, you call up your TPA and say, I'm a participant of the plan. We've got a request for this comparative analysis. We got to get it within 30 days, send it to me. Again, what you're going to get is probably not going to be sufficient, but at least you can get your hands on something. Are the documents requested from the DOL updated by our TPA every year? When should we request one to have one on hand for a DOL request? The comparative analysis don't need to be updated every year. They need to be updated when something in the plan design changes that could impact the comparative analysis. So it's an ongoing thing, but there's not necessarily a certain period of which they need to be updated. When should we have one on hand? We should have one. I would love for you to have one. I just found that it's difficult. There is a provider in the area, or a TPA in the area, of which I have clients that are under just a general health plan audit. It's not specific to mental health parity, but the comparative analysis was requested as part of that audit. This provider was willing to provide the comparative analysis that it based on its fully insured or underwritten arrangement that the self-funded plan was based on, but then give the disclaimer that says, hey, if you've made any changes to this in your self-funded plan, we're not responsible to document those changes. So again, this is a major TPA in the area. They've been willing to provide it upon request from the DOL, but otherwise they haven't been able to. But again, if you want, you could arguably call them up and say, I've got a request from a participant, even that if that participant is you, we need to provide this in 30 days, get it over to me. It'll be interesting to see what the DOL says. But again, in these proposed regulations, the Department of Labor has said the comparative analysis is a document upon which the plan is operated and subject to the general disclosure requirements like an SPD under, I think, Section 104 of ERISA. All right, last question. What if there's not as many mental health substance use providers in the area? That's something the plan sponsor can account for through review. Yeah, so again, if we have a material difference in network compensation, that's an MHPAEA violation. But if you can demonstrate to the departments that it's due to a shortage, that's not the plan sponsor's responsibility, and we're taking actions, whatever those actions are, maybe it's working with the TPA or looking at different networks or different TPAs to make up for that, the departments are not going to enforce that violation or penalize for that violation. With that, I've kept you for almost an hour, so I will let you get back to your days. Thank you all for joining us. Again, make sure you join us tomorrow or next week at our employment law seminar, and join us next month for our next edition of the employee benefits lunch break series. Thanks, everyone, and have a good day and a good month.